Good afternoon, everybody. I hope that you can all hear me. My name is Sarah Vinnicombe, and I'm delighted to be hosting this joint International Cancer Imaging Society and British Society of Breast Radiology webinar. I'm delighted to introduce my co-speaker, Professor Gerald Lipp from Aberdeen, who will be very well known to all of you. And in the next hour or so, we are going to try and give you a comprehensive overview of where we are with AI in breast imaging at the moment. Before I start speaking, I would like to thank you all very much for coming and giving up your lunch hour. I would also very much like to refer you to the ICIS website, where you can find all sorts of useful information about future meetings that we have, also regular webinars, which we do on a 2-monthly cycle, and courses on reading with the experts. It's all there on the website, so do have a look and sign up for the webinar if you're interested. I'd also like to take this opportunity to plug the BSBR annual scientific meeting, which will be taking place at the beginning of November in Brighton, and I hope to see lots of you there. So without further ado, I'm going to kick off. Just to say what we're going to do, I'm going to speak first, then Gerald's going to speak. If you've got questions or queries, please do put them into the Q&A and we will pick them up and hopefully have plenty of time to answer them all at the end. So I'm going to talk about AI in breast screening and where we are with it. My disclosures are not relevant to this presentation. And so when we think about breast imaging, there's obviously a lot of unmet clinical need, and the Department of Health would have us believe that AI can solve all our workforce issues. However, I firmly believe that we should be using AI to help us do better, to detect disease earlier, and also to better predict those women who are at risk of breast cancer so that we can start to offer personalized screening. Now, when we look at AI in breast imaging, you can broadly divide it into two groups. There's the non-interpretive broad AI, so scheduling, QA, display, workflow triage, and then there's the narrow interpretive pixel-based AI, including density assessment, risk prediction, computer-aided detection and diagnosis in the screening and symptomatic side, but also prediction, for example, of BRCA mutation status, cancer immunophenotype, and likelihood of response to neoadjuvant chemotherapy. And when we think about breast screening, the standard protocol is shown on the left of your screen there, double reading with arbitration. So we could use AI to replace one reader. We could use it as a form of assisted diagnosis or detection for one or both reasons. We could use it as a pre-screening triage tool to hive off those examinations that we're happy are normal, or to flag those ones that we think are ultra high risk, or of course we could use it to replace the radiologist altogether, which I don't think is going to happen. Before we have a look at where we are with breast screening, I just want to make a few points about the evidence. Now, in this paper from 4 years ago, Van Leeuwen et al. Looked at AI products that had FDA clearance. Most of them were concerned with radiology. And what she found was that only 50% of the evidence was independent of the vendor, and only 36% of products with a CE mark had peer-reviewed evidence of how well they were doing. And the vast majority of studies were just looking at diagnostic accuracy, with very little on patient benefit or societal benefit. Fast forward 4 years, we're doing a little bit better. And what you see now in the orange bars is that 66% of products have some peer-reviewed evidence out there, but still the overwhelming majority of the evidence is looking at diagnostic efficacy, once more with very little on patient benefit. So this systematic review from Katarina Freeman 4 years ago looked at 12 studies, all small, mostly retrospective reader studies, and none showed that the AI tool was better than 2 readers. And look at the bias, both in patient selection, index tests, comparator tests, but also with applicability concerns as well. And if we look at this meta-analysis from a couple of years ago, 16 studies now, many more women, mostly reader-enriched test sets, some historic cohort studies, some DBT. Now, when the reader studies were assessed, you can see that AUC on the bottom for AI was somewhat better at 0.87, but there was no difference between AI and radiologists for the historic reader studies, and there did seem to be some improvement for DBT, but Interestingly, when the vendor was involved in the study design, guess what? The radiologist didn't perform quite as well. Now, this paper from McKinney, it's hard to believe it was published 5 years ago now, but there's a couple of points about it which I think are relevant. It was a well-performed study. They had an external cancer-enriched test set from the US, and the other thing they had was prolonged follow-up so they could ascertain outcomes like interval cancers better. The first thing they showed was that when they applied the algorithm to the US test set, when it had been trained on the UK set, the performance fell. So you can see that the AUC goes down, and I hope this is my pointer here. Let's see if I can get that to work. The AUC goes down from 0.8 to 0.757. And the other thing they showed was that though the standalone algorithm was better than single readers, and this was the headline across all the papers, it was inferior to double reading, especially with arbitration and particularly in terms of specificity. But they did also estimate that there could be a significant workload reduction if AI was used as a second reader. Now, this slide just demonstrates the importance of external validation. And this was a study performed in Australia. And what it shows is that the area under the curve was lower for the AI algorithm. And more importantly, when they put the operating point to match the specificity of the radiologist, 97%, the sensitivity of AI was only 40%. Interestingly, though, it did pick up more interval cancers, and I'll come back to that. Now, ideally, what you'd like to be able to do is look at multiple algorithms on the same test set, and that's exactly what Matti Salim did. And what they demonstrated was that, as you see here, algorithm 1 clearly outperforms the other two, but once again, not as good as two readers with consensus. The most sensitive combination was algorithm 1 and one human reader, but that was at the cost of a significant drop in specificity. Now, the other thing you could do is what Yan Chen did. She assessed an AI tool with Performs, and this was a study using Lunit. And what she demonstrated was the area under the curve for AI and the readers was not significantly different. But at the vendor's suggested threshold, the AI tool did have higher specificity, as you see there. Now, what about DBT? Here's an area where AI really ought to be able to help us, because these are very, very big studies. And when we hear about the results of prospects in a month or so's time, if we're ever to implement DBT in the UK, we're going to need some help. And there's less evidence out there, but it does seem to reduce reading times. It does seem to increase accuracy. And in some scenarios, not all, it reduces recall rates. And this data that I'm showing you here is from Raya Povedano in Cordoba. And if you just look at the DBT double reading, what you see here is that with AI triage, there was a massive 73% reduction in the number of studies that needed to be read by humans, with at the same time a slight increase in sensitivity and a slight reduction of recall rates. So this all looks promising. Now, the other way you can use AI is for triage. As I've mentioned, you hive out the normal examinations, and maybe they have only an AI read or one human read. The question is where you put your threshold. And people have used low thresholds, 1 or 2, to avoid missing cancers. The Cordoba group have upped their threshold to 7 currently, and Sarah Hickman showed that between 17 to 91% of normal mammograms could be read by AI alone, missing between 0 to 7% of cancers. Now, a decision referral approach like that was used by Lauritsen in Copenhagen, and this was their retrospective study. And basically, a referral for human read was dependent on the AI degree of risk. So no human reads below a score of 5. Clear abnormals went straight through to assessment, but all the other intermediate ones where the AI algorithm was uncertain went for double reading as normal. And the take-home message here is that the false positives were reduced by 25% and the workload reduction was 63%. Now, the German group Liebig et al. Using VARA adopted a slightly different approach. They hived off normals with no read, but for all the others where the AI algorithm was either uncertain or confident, they didn't let the readers know what the score was. They all got read by the readers. And what they demonstrated was that the decision support triage performance in green here was better than double reading and the algorithm alone. And it was particularly better for the BIRAT C and D breasts and picking up small cancers, which are the ones that we want to pick up. But there's a lot of problems with retrospective studies, biases, training sets, age, race, ethnicity, verification bias, was follow-up long enough, limited external validation, the laboratory effect. We know that readers do poorer in a laboratory effect and their performance is more variable. And as I've mentioned, we need to use clinically relevant thresholds. Now, another problem is that by the time your paper's published, the algorithm may have improved significantly, so your work becomes somewhat irrelevant. We need to know if an algorithm performs just as well on different mammogram units produced by the same vendor as well as different vendors. We need to know more about the additional disease picked up by AI. Are we picking up the cancers that matter? And critically, we need to know about the impact that the AI as a second reader has on subsequent arbitration. And this is something that Gerald's group is looking at. Automation bias is a real thing. And in this very nice paper, there were 40 mammograms. And what happened was that when the AI prompt was correct, all the readers, inexperienced and experienced, did pretty well. But look what happens when the AI suggests the incorrect BIRADS category. Even the experienced readers are affected, particularly when the AI algorithm suggests a more suspicious finding. You can see here that the inexperienced readers are really badly affected. Now, something that's become apparent is that AI can pick up interval cancers. And in this work by Bing et al., at an operating point of 99% specificity, AI could identify nearly 30% of false negative and 12% of minimal science cases. And interestingly, it can even localize the point in a breast where a subsequent true interval cancer will develop. Now, what the Nijmegen group did was they add together Transpara, an AI tool, with a measure of density as well. And they did a case control study with an external test set. And what they showed was that the combined model performed pretty well. And at 90% specificity, the model could correctly flag where 51% of subsequent interval cancers would develop. And unsurprisingly, the best performance was in 1 year of the screen, falling to 2 and 3 years after the screen. And I can't pronounce that name actually, but the Norwegian group also studied this. And what they demonstrated was that if you looked at a series of screening mammograms before a screen detected or an interval cancer developed, you can see that the score gradually goes up for the screen detected and the interval cancers, with absolute differences shown here, whereas there's no change in the score of normal breasts. And this brings us on to short-term risk prediction. It has become apparent that using deep learning and radiomics-based approaches, we can define risk of subsequent breast cancer. And these image-based models work better than traditional models like Tyrer-Cuzick or density. And I commend this review to you, published very recently, which looked at 14 studies in total. And what they showed was that the image-only performance was significantly better than the clinical ones, Tyrer-Cuzick or density, and some improvement with the combined models too. So that's worth having a look at. I want to mention one in particular, the Mirai model. This was developed by Regina Barzilay and Connie Lehman in Massachusetts General. And with the first iteration of the model, what they showed was that for women with non-dense breasts but model-defined high risk, the incidence of subsequent cancers was increased 4-fold compared to women with dense breasts but model-defined low risk. They went on to improve the algorithm and they tested it in different US states, but also in other countries, Brazil, Taiwan, Israel, Sweden. And what they showed was consistently better performance than Tyrer-Cuzick, which you see here, regardless of age, ethnicity, and density. So this looks super exciting. And on the Massachusetts General high-risk cohort, that is Tyrer-Cuzick lifetime risk greater than 20%, the model outperformed Tyrer-Cuzick itself. Perhaps not surprisingly, the deep learning algorithms that work best for prediction of risk are those that work best for cancer detection. So here you can see that for cancer detection and risk, Mirai performs better than 3 other open source algorithms. And Mirai was the only one that performed well for small cancers, the ones we want to pick up. You can use similar tools for DBT, and Mikael Eriksson's done quite a lot of work on this, and it looks as if the image-defined DBT risk performs better than full-field digital mammography, with a theoretical increase in the number of cancers that subsequently develop, and in particular it could identify women at high risk of developing late-stage cancers. And if you look at what happens over time before diagnosis, you can see that the accuracy of the model goes down with distance from diagnosis, but at every single stage, the image model is working better than Tyrer-Cuzick for both screen-detected and symptomatic cancers. Now, I want to move on to the prospective studies now. So the fundamental problem we have with this is that in a screening population, there aren't very many cancers around, and that means we need large numbers in our group to show an effect on sensitivity for cancer detection. So you can either do a prospective comparative test accuracy study, and the advantage of this is that it's good for diagnostic accuracy, and because all people are assessed who have an AI or human reader flag, there's less verification and incorporation bias. Or you can do a randomized controlled trial, and this is better for looking at the effect on outcomes in terms of interval cancers and late stage cancers. And you can see there's a large number here. I'm not going to be able to go through all of them, but I'd just like to highlight a few. The ATTIC study took place in Cordoba, and what they did here was a randomized controlled trial, and either there was standard of care, double reading, no arbitration, or they used AI as triage and decision support. And their interim results after nearly 20,000 screens showed that there was a workload reduction of 64%, and there was a slight increase in the recall rate in the AI group, but the PPV1 was higher and the cancer detection rate was higher. Now, they have been using it in real life for a while now, and this was published last year in European Radiology. Nearly 12,000 women, either DM or DBT, matched to an equivalent size control group, and the overall results for DM and DBT are an increase in the recall rate, but an increased PPV1 and a significant increase in the cancer detection rate. And in particular, if you look at DBT here, the cancer detection rate is way up, as is the positive predictive value. And unsurprisingly, when you look at the mammograms assigned to low, intermediate or elevated risk, you can see that there was only one cancer in the low risk group, very reassuring, and most of the cancers sat in the elevated risk group, which is exactly what we'd expect. Now, in Copenhagen, they have taken a slightly different approach. Because they were so impressed with their study results, they actually upped their threshold. So now, mammograms with a score less than 7 are only single read by radiologists, and any mammogram with a score of 8 to 10 is double read as normal. And what they've found is that if you look at this table, the recall rate is significantly lower. The cancer detection rate is higher. The false positive rate is lower, and the positive predictive value is higher. And notice also that the small cancer detection rate goes up with AI support as well. And this is all with a reduction of workload of 34%. And then we have the Screen Trust CAD study from Karin Denbrouwer taking place in Stockholm. And this was a population-based paired reader study using LUNIT, actually. And what they essentially established with their workflow was that one radiologist and AI, shown here in blue, was non-inferior to the standard double reading in orange. In fact, a few more cancers were detected, as you see here. The exploratory modality that detected most cancers was triple reading by 2 readers and AI, but that was at the expense of a much higher recall and biopsy rate. And notice that if you just have AI with no human read, there's a very low abnormal interpretation and recall rate, but actually the number of cancers detected is not that much less. What is interesting is that in her work published earlier this year, she was able to demonstrate that radiologists don't trust AI. So what you see here is that if a case was flagged by the AI, not the human readers, the recall rate was low, but a lot of cancers were picked up. If a case was flagged by 2 human readers, but not AI, the recall rate was very high and very few cancers were detected. Whereas if it was flagged by one radiologist and AI, the recall rate was higher and the PPV for recall was also very high. So this is without an AI flag. Notice here the PPV is only 1 to 5%, whereas with an AI flag, we're looking at much higher PPV. And then finally, we have the only randomized controlled trial that's published, MASSI. This is just looking at the interim results here. So what they used was a triage system with decision support. And at the interim result stage, they had a few more cancers, a slightly higher cancer detection rate, recall rate a bit higher, false positive rate about the same, screen reading volume reduced by 44%. So the full analysis of cancers detected was published earlier this year, and you see that in the intervention route, the cancer detection rate is higher, the positive predictive value is higher, and reassuringly, the recall rate is not that much different, and the rate of consensus meetings wasn't that much different either. Now, this study is actually powered on interval cancer rates, and I suspect they'll be presenting at RSNA later on this year. And the final paper I want to mention is PRAME, and this is what the Germans did on the back of their study. Now, what's different about this is that the radiologists in the sites have the choice of whether or not they use the AI algorithm, and it's a triage type system with a safety net. And what they found is that of all the radiologists, 56% chose to use AI and 59% of the exams were just called normal, and they were read very, very quickly. With AI support, as we've seen with all the other papers, the cancer detection rate appears to go up a little bit. And from their safety net group, of which there were 4,000 instances, you can see still not all of them were recalled, but a large number of cancers were detected. And as you would expect, the normals are read very quickly. The situations where the algorithm isn't confident take a bit longer, and those that are safety net take quite a lot longer to read. Now, I couldn't finish without mentioning this seminal bit of work from Gerald's group, published a couple of years ago now, and this just shows why it's so important to monitor your system after implementation. Because when they had Mia running in the background, initially at the vendor suggested threshold, the recall rates were ridiculous. After calibration, they got that down to 13%. Notice that the first reader recall rate in Aberdeen was about 5%. Now look what happened when all of a sudden there was a software change on a couple of the units. You can see that Mia's recall rate shot up threefold, whereas there was absolutely no difference in the recall rate of the human readers. And this is just to make the point that after you've implemented, continuous monitoring as opposed to post-market surveillance is absolutely essential. So I hope I've shown you in this short overview that there is very good retrospective evidence for AI as an initial reader, and that evidence is emerging from for identification of women at increased risk, and the early evidence from the prospective studies and the real-world data looks really promising. We need a lot more work to be done, but people like Gerald are leading the charge, and I'm now at this stage going to hand over to him for his talk on other aspects of AI in breast imaging. Thank you very much.
Thank you so much, Sarah. And I want to also stress that there's a Q&A button there for questions and answers. If anyone has any questions or comments or things that you want to carry on in the chat that we can address at the end of this presentation, just type it in there and we'll try and answer on the fly as we're doing our presentation today. And obviously this will also be available after the webinar online on the British Society website, as well as the ICIS website. And yes, thanks for the really good introduction. And I'll just launch into the next bit, which is about AI, which is not memos, so everything else. And I'll click my share button there, and I'm on that, and click share there. And I'll just get Sarah, if you're on, to just confirm you can see the slides all looking okay.
Yep, I can. Thank you, Gerald.
Yes. So I'm Gerald Lip. I'm the current president of the British Society of Breast Radiology, and give tribute to Sarah, who was the past president two presidents ago of our BSBR Society. And I'll speak about AI beyond diagnosis, so all the other parts of AI, breast imaging AI. And these are just my declarations and disclosures. And on to other modalities. So mammography has been very, very well covered in the first 20 minutes. And I'll talk about our Gemini study, which is in publication very soon. It's been accepted by the journal, so we hope to have the preprint out, and you'll see it all over LinkedIn and everywhere else when that time comes. But that Gemini study was a safety net study, and we just basically engaged it after we said everything was normal, and it flagged up extra cases, and we had similar figures, 10.4% more cancers detected. And interval cancer analysis is also being done, and we're seeing similar numbers of interval cancer pickups with the model. So AI does work. Ultrasound. So ultrasound is really used a lot in the rest of the world, and I recognize this is an International Cancer Imaging Society webinar, particularly areas like China, where ultrasound is the primary form of screening rather than mammography because of the physique of Asian women. And we also use it in our clinics. We are using one of these ultrasound AI tools currently, and it's for lesion detection, characterization, classification, and re-education as well. I use it to sort of train the registrars and get them quite good at it and build it up along the way. I'll just move that slide. Is that okay, Sarah? Is it still showing? Yeah, that's fine. Thank you. And there are some very early research models of ultrasound looking at whether it can link to.
Sorry, Gerald. Sorry to
Yeah.
interrupt. I've got a slightly different slide on my
Um,
screen now. Oh, there we go. Yep. We're
Okay,
good.
sorry, yeah.
Yep. Yep.
Looking at early research on tumor types, elastography, and we're looking to see whether, and the key part of any AI integration, as you've seen in mammography, ultrasound, or wherever, it needs to go in your workflow. Ideally, one button or almost as an image, the next image. Because if you're going to have any friction trying to move through, it's not going to support your efficiency. And there are a few companies in the ultrasound space at the moment. This is a nice paper by Simon Schifano on AI in breast imaging, and it covers mammography as well as ultrasound, MRI, and all the other factors that I'm speaking about today. So if you want a formal sort of paper, Simon's paper is really good, and it was discussed at USOBI, which was in Aberdeen 2 weeks ago, last week. And why ultrasound for our practice in the UK? This is a paper from the British Society Committee on fibroadenomas. And fibroadenomas, if you follow Stavros criteria, are benign lesions. And you could probably raise the age of biopsy. Currently, some people as young as 20, in other parts of the world, 25, 30 are getting their biopsies. We feel that we can safely raise this age, and the survey of national practice shows quite wide variation despite guidelines in the UK. So again, classic fibroadenoma, oval lesion, mixed echogenicity, with a benign rating that's given on this particular ultrasound AI program. And this is probably something that we have done a bit of research on in Aberdeen, and we've shown that it's quite effective for the 44 fibroadenomas just this year so far that were under 35, and we gave a score of U2. The AI concurred as well. So we are actively looking at this as a tool possibly for that in future. And you can see the measurements and all that are in. So you have an integrated system. It goes straight into your PACS as well and your risk reporting. Where again, this is an international society, and this is a place in Kenya. And this group that is being led by Christina Lang, who did the Maasai trial, is looking at helping community support workers, so non-specialists in ultrasound, using your phone and using a handheld POCUS type ultrasound tool, and just saying malignant or non-malignant, because that's basically triage. So some of these people have to travel hundreds of miles on foot to a community center. And by having these tools with early detection, it helps prevent, because most cancers in developing countries may present quite late and at higher stages. And that's an increased cost and burden on mortality as well in this population. So I think that's part of where ultrasound is sitting at the moment in the other parts of the world. Contrast enhanced mammography is really becoming quite popular across multiple centers because you don't need to have an external. Some places don't have MRI on site or have to go elsewhere. So you have your existing mammo machine, you can upgrade with a software and get a pump and inject mammos. And again, this is early research looking at trying to use the radiomics, those little signals on the black and white pictures, and try to do subtypes. So you can say, it looks like this. It's becoming to have this sort of area of enhancement or signet ring enhancement to try and develop a bit more prognosis. The other area of AI development is synthetic contrast. So this is a research tool, and this is your standard dense breast tissue. And this picture on the right doesn't have any contrast. This is a synthetic picture using the different energies and AI. So very interesting, because if you don't have to use contrast, and you can use your existing machine with an AI tool. So watch this space for that in future. It'd be quite interesting to see where that comes. MRI is our next space that we move into. And there are lots of different use cases for MRI. There's a nice research paper there. And we're seeing that being used in segmentation tools based on this radiomics principle and deep learning as well. You can classify the lesion. You can look at the enhancement curves. You can try and characterize the cancer and look at tumor response, as well as risk assessment. There was only one FDA-approved company I knew of in breast MRI, but that's no longer active. Well, it's not on the website anymore. And I know that some of the manufacturers, your big companies that do your MRI machines, they are developing their own MRI tools, whether just for segmentation or trying to develop further into characterization and triage. The next slide shows some triage things. So this is Ritza and Katja Pinker, and looking at adaptive breast MRI. So they've trained a model that can say normal. One thing that you see from Sarah's presentation earlier and mine to come is that AI is pretty good when it says it's normal. The miss rate of human is about 1 in 1,000 for mammography, but in AI tools, I'm seeing it as accurate when it says it's normal as 1 in 7,000, 1 in 10,000. So very good when it says normal. So they're using adaptive breast MRI scanning. Says normal, you don't have to go and do the full sequence. You just stop at the fast MRI sequence. So already you're using your resources better, and you're optimizing what you have. Other MRI applications, loads there, and using all AI, because remember the MRI signal is your protons. You create your sort of K-space central and peripheral, and then that has something called a Fourier transformation. All that is technical mathematics. So you're going to fill that space with reconstruction. You can use AI tools then to improve the quality. You reduce that scan time. And there are several papers just showing the sort of headings that we have there. Generative AI, they're trying to use that instead of AI tools to fill this K-space. So you can do your sequences shorter. The patient doesn't have to have as long an MRI. And contrast is another sort of very big area again. So I showed you the contrast, the synthetic area there. We're seeing that now in CT scans. They're trying to do virtual contrast instead of injected contrast. And if anyone was at ECR, European Congress of Radiology last year, you have seen that the green sort of energy saving, save the world kind of ethos is very much strong there. And that's with contrast use as well. Linda Moy gave that big keynote, and you were like, we find gadolinium now in shellfish and oysters, and you're eating it. So it's something about trying to look at a different way. And I really applaud the guys who are developing this kind of research and technology. This is just a different kind of approach to MRI now. We're doing some research in Aberdeen on low field and field cycling. So do we need these big 7 Tesla scanners when you can probably do similar with lower fields? And then these are more portable machines, because the low field MRI we have here, I can walk in with my belt and everything because it's as strong as a fridge magnet. So that's something maybe in the next 5 to 10 years that you could see as more portable MRI in future. So lots of in futures here. Let's go to our cousins. Our other issues there. As Sarah said very earlier, there's lack of training data sets. You're going to have problems with different MRI machines in different centers with different sequences. Someone's T1 sequence is different to somebody else's T1 sequence. One manufacturer might have a Vibe, or someone else has a Dixon. So it's different ways to try and merge all that data to train a set. So you might have something very good for your institution, but it may not be transferable to other institutions. And as we've shown with changes in software that can just affect mammograms, imagine changes in software, hardware for MRI machines. And again, we have the workflow issues there as well. Pathology. So our cousins across the way and our fellow diagnosticians, pathology is a huge area, and I think pathology is following radiology in 2 to 5 years' time when you start bringing in more digital pathology and whole slide imaging. And with pathology, we're going to talk about, again, classification, just like we did with all the other fields. You're into the lymph nodes as well, so you can get really good classification accuracy. Pathology is the truth, so you can see the actual H&E slides, and then you can count the number of tumor cells. So then you can start moving into areas like prediction, looking whether if you have these slides and this imaging and you know you're going to give that treatment, prediction of full response, because that can lead to de-escalation, less surgery or less chemo or kinder chemo for or use of new therapies like the immunotherapies and CD4, CDK inhibitors that are coming. Fish and HER2 assessment is always a problem. You've been at many tumor boards where they go, oh, HER2 equivocal. So hopefully technology again can make it a bit better and reduce the expensive tests that we have to use. Our pathologists don't do Ki67, which is a mitotic index. It shows how active or aggressive a tumor is because we don't have resource. But again, this is something you could probably automate using technology. Pathology, other things there, we're looking at the Ki67 mitotic counts. TILs are tumor infiltrating lymphocytes, something that's a lot of research is going into to see if these floating leftover cells are predictive of recurrence of breast cancer to come back, and grading there. There's a lot of commercial companies in this area, but they're all quite small at the moment, just waiting for something to really break through. But the benefits in grading time, diagnosis is faster. It's probably at the moment when we have different pathologists looking at different slides, there might be some variability between human beings. Hopefully you get some standardization again with the computer. And this is just an example of segmentation tools that are being used for different types of tumors that you see in the breast. And prognostic biomarkers, then from that simple H&E slide, you can get so much information, just as we are showing that from the mammograms, you can get as much, even more information out from those black and white pixels. There are barriers in pathology, just as there are in radiology. Very good data sets are not available. Whole slide imaging is not really mature yet. You have these slide scanners, they take up a lot of memory and space, more than a few CTs in one slide, because you're really scanning the whole slide to different details. Each lab has different ways of staining. Some of the areas have pinker pinks and more purple purples. So it's just, again, variation again in the H&E. I'm not a pathologist, but I'm the son of a pathologist. So I have grown up around this environment. And you have false positives and negatives leading to different types of grading as well. So pathology is coming towards radiology in the digital space. Got the last 5 minutes here, and I'll go into a few other areas where we can help with broad AI. Ambient, AVT is what you hear, ambient voice technology. And this is basically an AI listening to you while you're doing your consultation and then scribing and writing the note and then saving that consultation on the side. We do that with our OSCEs now. We're bringing that in with medical students, and they do a history of Breaking Bad News, and the AI is listening and scribing it and actually giving them an analysis of how they did in doing those situations there. And again, when you have a consultation, you want to be looking at your patient. A scribing tool is actually something in the background that can just capture it. You both look at it, you both agree and sign it off. Our GP colleagues are really big into it. I can see it coming to breast clinics as well. Chatbots are coming in as well. In the UK, we have very strong information governance and GDPR rules. So like my guy says, you're not doing a chatbot because they'll put their name and everything into it. And I went, but what if it has auto language and they can find out more about screening? So that push-pull is still happening in the chatbot world. And research and drug discovery, AI, large data sets, looking at those proteins, looking at how things can develop using AI tools to find those trends that we didn't know about. Who would have thought, well, linking smoking, obesity, all those other areas, the effect of these weight loss drugs, the Mounjaro, on cancer in future? I think that would be quite interesting to see. We use a large language model in the poster that was accepted at ECR, and we have 7 trials currently running in our center. And we have the inclusion and exclusion trial of the platform, and we have a tumor board patients coming through. We ran all the models through. We ran anonymized patients through against a large language model on these 7 trials that we run in our center, and we found that lessons there were you had to have good prompts. You need to teach these LLMs, and we got up to 90% accuracy. So if you didn't have a research nurse or you wanted to enroll people in trials, there might be an automated way of bringing people onto trials, just saying from your tumor board list and say, these ones are suitable for the trial. And so we're learning lessons on that for tumor board management in future, and that would be pretty useful. Key considerations: post-market surveillance, as we have stressed earlier in the talk from Sarah, a strategy to deal with your new hardware and software. If the AI is only trained on this data set from that machine in the past, and you have an entirely new machine or photon counting CT or whatever, some new technology, that AI is not going to work anymore. But you've already taken away staff that would reading or doing mammograms or work in the future. So what do you do there if you're having that situation? Price and procurement remains a health economics, and for us in the UK, a nice issue, which is the clinical evaluation to see, is it worth it? Are we going to pay for this? Working with humans, training our humans, because there's automation, there's belief in AI, there's also disbelief in AI. So you have two different ways of interacting. We have juniors who are not so experienced as we are, and we find that there's a risk of automation bias where they'll just accept everything the AI says and says yes, 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 yes. So again, you need to train people to be strong in their foundations before they start using AI. There's questions about bias. A lot of data sets are trained on the Western world, white populations, and you want a more representative data set that goes across the whole population. This was our paper that Sarah mentioned earlier already, so skip over that. And in the future, well, foundational AI and multimodal models. You hear these buzzwords out there and they're thrown out by the companies. But foundational AI is again deep learning, machine learning. The next level is foundational, where they're going to use a lot less information to try and build better models. And I think it will get you that 0 to 70% of the way, but you're still going to need traditional models for that next bit up. So this is an example of a combination of multimodal brain MRI, multiple different sequences, different ways then of seeing that brain tumor, and now you're linking it to the pathology, and you're starting to have better correlation between what you're seeing, the radiomics, and what you're seeing in the pathology to really start developing. As we know, that we classify breast cancer into the 4 subtypes, but really there's probably 300 or 400 different subtypes of the subtypes. And if you can get into that level of detail, then we're starting to talk real personalization. What's the best treatment for my cancer? What's the best therapy for my cancer? And you connect these two adapters, and then you start having survival scores and building it along that way. This is the AI of everything. So you could take in your tomography, your dermatology, your urine, and into one giant model, and you pull it all together with the best of PubMed and the best of your EPR, electronic patient record. But I think the day of having such a beautiful connector system is probably very far away from all of us. And then new technology or optimizing old technology with AI. There's always been thermal, which has been talked about with AI. There's been a new areas of quantum or optoacoustic imaging, again enhanced with AI. Low field I spoke about earlier, molecular breast imaging. So could some of these other areas get AI enhanced or improve their sensitivity and specificity using AI? So data is going to get bigger. It's going to move all to other cousins or other ologies. We're going to try and build multimodal data sets linking things together. The AI companies themselves, those first generation ones from the retrospective studies to where they are today, it's been so fast. Those models have been updated, and they are getting better. And we probably need some different kind of trials or virtual trials that can model these better for the future. So that's me for this bit. And I think we'll go and launch straight into a bit of a Q&A because we've got 15 minutes left. And I think questions are coming through.
I'm just going to unmute myself there. Well, I hope my Q&A bit is working because I actually can't see any questions at the moment. And I've looked in the chat and I've looked in the Q&A and it appears to be a big blank. So we may have overwhelmed everybody. Oh, there's a question. I think there might be a question for you just coming in now. Somebody said hello to you, but I don't know if there's an actual question there.
Well, I'm sure it's being typed in the meantime, but I think you and I could talk a little bit there. The other big prospective trial that's coming in the UK is that 700,000 women mammo trial.
Yeah.
Yeah, and that's EDIF trial being led by Professor Fiona Gilbert and Sean Taylor Phillips in Warwick as well. Is your center involved in that study as well, or are you applied to be?
No, we will be part of it, but given the significant IT and IG hurdles, what I've said is that I would like us to be involved a little bit later after some of the teething problems have been sorted out, because the reason I suggested that was that we have had IT issues with Paxfin, our trust. And also, I know from bitter experience that as part of the BRAID study, looking at supplemental screening for women with dense breasts, we were required to transfer all our images to Cambridge, and that took 15 months to sort out.
Oh,
So I thought,
wow.
okay, let other people lead the charge and be at the front of the vanguard, Gerald, and find out best practice for how to get onboarded in terms of IT and IG. And then hopefully we will be joining, because I think it sounds really exciting and it's very, very important. I mean,
And
it'll be the first RCT to evaluate multiple algorithms on a cloud-based platform, as far as I know, won't it? And I think that's a huge step forward.
yes, and for the people, for all our participants in the webinar, a question has come through about how you think AI can be used in future in breast screening.
Yeah.
So I think the BRAID trial is really interested in looking at this. Sorry, the EDIF trial in the UK. So 700,000 women, 30 centers, multiple AIs, three different arms. One arm is a bit like what we saw with Masai, which is the one human and the other, the two humans versus a human with AI.
Mm.
And then the other arm is a bit like Priam, the German study, where you're told whether it's high, intermediate, or low risk. And then as a radiologist, you say, yeah, I'm going to do that, or I'm not going to, or I'm going to accept the AI. So safety net in a way. And we're just trying to find and tease out, because it's small numbers of cancer, 600,000 over 200, 600,000 women, to get these effects to see which effect is the best of which arm. But already, you said in your presentation, Sarah, that there is AI already being used in breast screening in several countries. So
Yeah.
was that Cordoba, Spain?
Cordoba, yes, Copenhagen. And I think in some ways, ironically, it's much easier to set up and get going with it if you have a small centre that you have autonomy over. Whereas trying to get anything done in a national breast screening programme is much more difficult, isn't it? But
Yes.
if you're in a centre where you control everything, you can evaluate it, you can see what works best, you can set your threshold taking into account the skills of your readers, all that sort of thing. So it makes it a bit easier, doesn't it?
Yeah, definitely.
Mm,
So I think you can manage your center, but if you're in a national program, you probably want a national approach because of funding and allocations as well.
mm, mm.
But yeah, we're definitely seeing some places in Spain, Sweden as well, and in in Denmark. I
Yes,
know Region Copenhagen is one of the four, but then
yes,
you're going to a few different other regions now that
yeah,
they're applying to do it. So the Scandies are ahead there
yeah,
on doing it,
yeah,
and I believe other countries in the world are definitely looking at that through. There's a question on the chat about POCUS, which is what I
yes,
mentioned earlier, and yes, so this company, if you look at it, is called N23, which is Christina Lang is the medical. But Christina Lang, who was involved in the Maasai study, is now involved as their medical advisor, and they're looking at low resource settings in Kenya, I believe, 8 centers there, and again, young women and all women actually trying to use the tool, and basically says cancer, no cancer. It's not going anywhere deeper than that, because if it says cancer, then great. But if women are young and they're feeling pain, dense breast, and do the ultrasound scan and it shows nothing, then that's pretty good. You don't have to go and travel any further. Your community worker comes to you
yes,
in your area. So
absolutely. And in
yeah,
terms of scalability, it's much more feasible, isn't it? I think that whole area is really very exciting indeed, and much more feasible than expecting people to get to a mammogram machine. I quite agree with you. And we've
yeah.
got a few questions coming in now, which is great. So really good question from Becky. Do any of the studies comment on the carbon impact for each vendor? I think that's a really excellent point, because the carbon impact of AI, as we know, is huge. I'm not aware of any particular studies that are vendor specific off the top of my head. Are you, Gerald?
I think it's because the machines are already in place. So and the population is there. So the only other carbon impact is the use of the algorithm and whether the algorithm uses more energy. For the AI algorithms that we talk about, these deep learning models, they're just they're not the same as the generative AI ones. So the generative AI ones, especially if you're using OpenAI, they use huge amounts of energy through data centers, the Chat GPT stuff. But the models that we talk about now, these FDA approved deep learning software models, they're just like a Windows software. They don't use any much more energy to analyze. It's the same as any other extra computer program that sits on your computer. So
Mm.
carbon impact is very low for standard conventional AI models. Carbon impact is very high if you're using generative AI.
Right.
Um,
Brilliant.
for the training data sets for rural technology, I think ultrasound is actually more reproducible. Sarah, and I mean, in my experience, I haven't seen too much variation in ultrasound waves and feedback into and it's a more mature technology almost because we've been
Yes.
using ultrasound for many years.
Yeah.
So the main problem I think for rural settings, and I don't speak as an expert on this, I think is if you find too much, you may not be able to do the next layer because it's like a traffic light. You find more cancers, but you don't have any breast surgeons or you don't have any oncologists or
Yeah.
radiotherapists in the low and middle income country. So
Yeah.
it's sort of having almost a whole country, whole nation infrastructure was even possible
Yeah.
to manage
I,
that.
I agree. There was a recent review of AI in breast ultrasound. I think it shows great promise, but I agree with you. I think going back to basics, you would expect that there to be somewhat less impact on how the algorithm performed with an ultrasound machine compared to, say, a mammogram machine. So hopefully the manufacturer settings and the training data sets wouldn't have quite so much impact. But I think it's an excellent question because there's a real paucity of evidence out there for ultrasound compared to mammography, isn't there? And
Yes,
these are very important questions that do need to be looked at.
my own research groups are in discussions with I think Sri Lanka and Angola. So we are exploring what we can do with local organizers there on
Yeah.
POCUS, but we're not as developed as Christina's group is, who's they've
Yeah.
gone all out with 8
All
centers.
out there. Yes, yeah,
Yeah,
very,
really
very
impressed.
exciting. And I think there are groups in the States who are also doing a very similar thing. Oh, I know that Wendy Berg and Vicky Mango have been doing stuff
Oh,
with
Vicky
that as
Mango.
well. So, yeah, yeah.
Yeah.
So very, very, very exciting. Yeah. Um, oh, here's Richard throwing in a whammy to us here. Aside from Edith, where do we see the best avenue scenarios to finally start deploying these systems in the UK? Well, there's a very good question, Richard. I'm not sure I know the answer to that. I think it's important that we do, Edith. And as I was saying earlier, I think the problem with the NHS breast screening programme is that because it is a national system, there is much more inertia and it requires much more to get something off the ground. And we have got to cope with the fact that in every of the 80 screening centres in England, practices are slightly different, mammogram units are slightly different. So it's going to have to be cloud-based, but there's got to be a way of testing the performance of the algorithms locally and factoring in the different performance of the individual readers. So my own feeling is that it's probably going to be much easier to introduce AI into the symptomatic service. Actually, I would love for us to be able to use AI as decision support in our 2-week wait clinics, because certainly at our site, that's the only group of women whose mammograms are not double read by two human readers. And the incidence or the expected incidence of breast cancer, it's going to be much higher in those women than it is in a screening population. So that's probably the best way forward to get it introduced reasonably quickly, I would think. I don't know what you think, Gerald.
Well, if anyone knows me, they know I like my tech. So we're already using breast AI ultrasound
Yes,
with a vendor in our clinic, and we're trying to build enough of an evidence base to
yes,
sort of say no biopsies of fibrinomas. We might
yes,
even try and get up to 40.
yeah,
We are in the discussions now, and we're probably going to get a tomo synthesis 3D AI company again, as you say, in clinics for triage, for trying to make sure that we're not missing any extra
yeah,
cancers on tomo through the symptomatic system. And then moving on to screening, because in the UK, our big boss is called the UK National Screening Council, and they have to say yes or no. So we have to provide a lot of evidence, whereas our friends in Copenhagen, they manage it by their region or state. So if they can convince their
exactly,
state authority, let me use AI, then they get to use AI. And I know that
exactly,
these business cases are being prepared at state level. In
yeah,
Germany, 40% of AI with VARA, they continued on. So they're now
yeah,
using it in Germany. Uh,
exactly.
in the same way because their vendors are there. In the US, AI is
Mm,
being offered as a sell-on. So in
yes,
like one company said you want to pay 50 to $150 to have AI
yes,
help your radiologist.
yeah,
Um, about 40% of people are paying
yeah,
because
absolutely.
that's the perception.
Yeah,
Yeah.
absolutely.
Richard,
Um,
another question there.
and that's a really good one. And I think we can probably both speak to that. When the braid results were published, I'm sure you all know, but just to remind you, what braid showed was that for women with BIRAD C and D breasts with an allegedly normal screening mammogram, that the supplemental cancer detection rate with supplemental imaging from the contrast techniques, um, contrast mammography and MRI, was 19 per thousand, 17 to 19 per thousand. It was much lower for ultrasound. It was only about 4 per thousand. But the problem, obviously, is that about 40% of the UK population probably have BIRAD C and D breasts, and there's no way that we can offer supplemental MRI or CEM to all those women. So the feeling that we all have, and we've started to have discussions to this effect, is that some form of image-based assessment of risk is absolutely the way to go. So if you take women with BIRAD C and D breasts, run it through what algorithm you want to use, Profound AI or Mirai, whatever it might be, if you can identify a group of women, a subset of women with very dense breasts who are at high risk, maybe those are the ones that you then offer supplemental contrast-based imaging to. So I think that it's going to be super important, and I think it's the only way that the Department of Health in the UK is going to be able to cope and in any way approach the idea of personalized screening.
Yeah, and what I'm seeing is that most of these supplemental imaging AIs or tools are getting down to about 8 or 9% rather than the 40% of our CND.
Yes, exactly,
Yeah, and at that
exactly.
numbers, then you can say, let's do a prospective trial of this 8% of women in
Yeah,
screening, and
yes,
do give them another mammogram or something at 1 year or 18 months.
yes,
So, son of
yeah.
braid 3.
Son
Of,
of Braid, yeah. Well, the
yeah.
other thing we probably should just mention, and I didn't have time to mention it in my talk, but the other thing is obviously the Screen Trust MRI trial.
Mm-hmm.
Because what they basically used was an AI algorithm to look at mammograms and define a group of ultra high risk women. I forget the absolute cutoff that they used. I think it was about the top 6% off the top of my head. But then those women were invited to participate, and if they wanted to, they were randomized to supplemental MRI or not. And what they showed was that the cancer detection rate in the group who were randomized to supplemental MRI and had MRI was 64 per thousand. Which is really pretty unbelievable. I mean, I am absolutely staggered by that, but it just goes to show, I think, the value of, or the potential value of a risk-based algorithm to identify those women who truly do have increased risk.
Yeah, and credit to Dr. Friedrich Strahn and his group in the Karolinska in
Totally, yeah.
Stockholm for something really different and unique. Um, we have no experience with AI locally. So, what is required for local IT? I'll do a plug here for the British Institute of Radiology, and we do AI sessions on introducing AI locally and give a framework as well. And obviously, our other group, the Royal College of Radiology, has an AI Global Congress, and I'm in charge of the education session there in June of next year. And we've just had our chat. Our very first session is going to be, how do I start? So a different plug there if you wish to. But generally, you need to engage your local IT and e-health. You form a sort of maybe an AI committee that says, looks at tools and says which one's the best for us, and then move that along. And then you have to look at resources and funding because you need a server on site. You probably need contracts, and it can be a 12 to 24-month process because information governance and data protection guys get involved as well. But don't lose heart.
Absolutely.
Don't lose heart. It's worth
Mm,
it
mm,
when you get there,
yeah.
but it takes a while. But you need good senior support from senior management and stakeholder engagement.
Totally. I mean, there has to be a willingness, doesn't there? And I wanted to ask you, Gerald, about your experience of AI for ultrasound. Are you doing it as a sort of service evaluation, or is it a right? Okay,
Yeah.
yeah. I think
Uh,
that's probably the way to go, isn't it? Yeah.
Service evaluation, so it's different people have different ways as well. You could do your standard research trial, but if you are maybe you don't have that resource or university access, service evaluation is another route where you sort of do the first 500 cases, you do an analysis and take it on from there. In Scotland, we have innovation hubs. So the
Yes.
north is all the big hospitals up there, and the east and the west, and you go to your innovation hub and say, we've got a few ideas here. And then they usually have a project team that takes on or assesses, do they want to take it on? I'm sure there's the same in England.
Yes, I must, having worked in both the English and the Scottish systems, I have to say that perhaps it's a question of scale, but everything struck me as being much better organised in Scotland than it is in England.
We
And
still miss you. We still
yeah,
miss you very
oh
much.
bless, yes. Well, if it weren't for the weather, I'd come back up and see you all, but there we go. Well, we now have reached 2 o'clock. And I'm just having a quick look to see if there are any more unanswered questions. I don't think there are. You've got our email addresses from the talk, and as we mentioned at the start, this will be available to rewatch on YouTube in a few weeks or so if you want to revisit it. If you do think of burning unanswered questions, please do get in touch with us. We'd be delighted to answer them. But in the meantime, on behalf of Gerald and BSBR team and myself from ICIS, thank you for joining us this lunchtime. I hope you found it useful, and we look forward to seeing you either at BSBR or at future ICIS meetings as well. Thank you very much, everybody.
Thank you very much. See you then. Bye bye.
Bye.